This video is sponsored by Bootcamp.com. Check it out for INBDE prep and use coupon code MENTALDENTAL for 10% off. Hey everyone, Ryan here, and welcome back to our oral medicine series. This video is going to be about substance abuse, which is a big important topic for the new integrated board exam, and it wasn't so much covered on the older exam, so I want to make sure we focus on it for this one. Beyond that, the abuse of drugs and alcohol is a large public health problem, so let's talk about the effects of drug abuse as they pertain to dental management. Let's start with some important definitions. A diagnosis of substance abuse requires the recurrent use of a substance over the past 12 months with subsequent adverse side effects like interfering with work or school-related tasks, contributing to relationship problems, leading to high-risk situations, things like that. Dependence is the uncontrollable need for use of a substance despite these adverse consequences. It's also defined as addiction. Dependence often includes the following two bullets as part of its diagnosis. So, tolerance is the need for an increased amount of a substance to achieve the desired effect, or a diminished effect with use of the same amount of a drug. Basically, your body gets used to the drug and craves more of it. And withdrawal refers to a group of symptoms that emerge upon abstinence of a habitually used substance. And these symptoms often include irritability, insomnia, difficulty concentrating, to name a few. Next, let's go over some epidemiologic data. Currently, 8.7% of the US population 12 years old and above are illicit drug users. That means they use drugs that are illegal. Adult men are 2 to 3 times more likely than women to develop drug abuse or dependence disorders. The most common age range is between 18 and 25 years of age. Interestingly, it's also more common among dentists and other dental office personnel as compared to the general population because of the easy access to opioid analgesics, sedative drugs, and even nitrous oxide. Almost all of the major drugs of abuse that we'll talk about in this video disrupt the endogenous reward system of the brain primarily via dopamine circuits, explaining why they are so addictive. So first, we're going to talk about marijuana. Marijuana is manufactured from the cannabis plant and is the most commonly used illicit drug in the world. Delta-9 tetrahydrocannabinol, or THC, is the major psychoactive ingredient. It's most often smoked, but can be taken orally alone or with food. The peak effects are felt in 20 to 30 minutes with inhalation and in 2 to 3 hours with oral administration. In the US, some states allow the use of marijuana for medicinal purposes, and the primary medical effects include pain reduction and seizure alleviation. Most users also describe an altered sense of time and distance perception, and intoxication or overdose can cause anxiety, paranoia, and delusions. It can also destabilize someone whose schizophrenia is currently in remission. Abuse or chronic use can lead to chronic bronchitis and airway obstruction via smoking, and with large doses, orthostatic hypotension. So for a patient with heart disease or heart failure who is taking large amounts of marijuana, dental treatment should likely be postponed until that patient is stable. And we'll talk more about the specific oral manifestations like xerostomia at the end of the video. Lastly, I use THC as a memory tool to help me remember some of the symptoms of intoxication and chronic use, which include tachycardia or rapid heartbeat, hallucinations, along with delusions and euphoria, and then, due to the irritants from smoking, airway issues and chronic bronchitis. Next, we have opioids. They come from the opium poppy plant, and they're derived from naturally occurring alkaloids, morphine and codeine, which are called opiates, the natural form of opioids. Opioids are also considered narcotics, a category of drug that modulates your mood. They can be administered orally or intravenously. And the major complication with any IV drug use involves using contaminated needles that can spread diseases like hepatitis B, hepatitis C, and HIV. How they work is they inhibit the ascending pathways of the central nervous system via mu-opioid receptors, and their primary effects are to decrease pain perception, cause modest sedation, and produce euphoria, the high that drug addicts often seek. And they do this by depressing the central nervous system. Side effects include things like nausea and vomiting, constipation, pupil constriction, and respiratory depression, which is a big deal. Opioids can make a person very drowsy and can depress their breathing to the point where it cuts off oxygen to their brain, causing brain damage and even death. Naloxone, brand name Narcan, is a reversal agent for someone having overdosed on opioids. The nice thing about Narcan is that you can't overdose on it, and it can be given safely to anyone. And if they're not on opioids, it'll have no effect on them. So never be afraid to give it to someone suspected of having overdosed. Use of a prescription drug monitoring program is recommended, and a DEA number is required to prescribe opioids. So this PDMP is an electronic database that tracks controlled substance prescriptions in a state, and PDMPs can provide health authorities timely information about prescribing and patient behaviors that contribute to the opioid epidemic. And the DEA is the Drug Enforcement Administration, and we'll talk more about this later with regards to drug scheduling. Here are some examples of some opioids. We have morphine and codeine that are naturally made opioids or opiates. We have heroin, oxycodone, and hydrocodone, which are semi-synthetic opioids. Fentanyl, methadone, and tramadol are synthetic opioids, meaning it's entirely made in a lab. And then we have Percocet, which is a combination analgesic containing oxycodone as well as acetaminophen. And Vicodin is a combination analgesic with hydrocodone and acetaminophen. Next we have cocaine. So cocaine comes from the coca leaf, and it's a stimulant, which means it stimulates the central nervous system. It's also a local anesthetic and potent vasoconstrictor. And that might not be surprising because it's a cane, just like lidocaine or septicaine. After alcohol, it is the leading drug of abuse in terms of frequency of hospital admissions and domestic violence. It can be administered orally, intranasally via snorting, topically on mucous membranes, intravenously, or by smoking it. And IV use is once again linked to the risk of transmissible bloodborne diseases. Its mechanism of action is to block the reuptake of neurotransmitters, particularly dopamine, serotonin, and norepinephrine, keeping them in the synapse and giving that feel-good high that drug addicts seek. One of its big side effects is that it's tough on the heart, so abuse can lead to tachycardia, arrhythmias, hypertension, pupil dilation, and heart attack or stroke. Now compare this to opioids that slowed everything down and were instead hard on the brain and the lungs via respiratory depression. So cocaine, since it's a stimulant, can initially make people very alert and restless, whereas opioids make a person drowsy. And if cocaine is taken together with opioids, it can mask the appearance of an overdose because the effects basically cancel each other out. One excites while the other depresses. So mixing these illicit drugs together can be even more dangerous, masking the massive amounts of damage they can be doing on the human body. Next, we have amphetamines. Amphetamines like methamphetamine are psychostimulants of the CNS, or central nervous system, and they are manufactured synthetically in a lab. They're taken many of the same ways that the previous drugs can be taken, orally, intranasally, IV, or inhalation. The mechanism of action this time is to cause release of dopamine stores into the synapse directly, producing a dopamine high that is more intense and longer lasting than that of cocaine. Also, the half-life of the drug is much longer than that of cocaine. It can be used clinically for attention deficit hyperactivity disorder. Adderall is an example of that. It can be also used medically for weight loss, narcolepsy, and treatment-resistant depression. Higher doses and abuse can lead to tachycardia once again, because we're talking about a stimulant here, hyperactivity, hyperalertness, dysphonia, that's difficulty speaking, headache, and confusion, and a lot of the psychotic symptoms similar to what you'd see in schizophrenia. Sedative hypnotic drugs are used as central nervous system depressants to treat anxiety and seizures. Benzodiazepines are the most frequently abused sedative hypnotic drug, in part because they are commonly prescribed. Barbiturates are behind the benzodiazepines in terms of how much they're abused because they're no longer used extensively in the clinical setting. Longer use or higher dosage is more likely to lead to dependence, but dependence can also occur with low doses used for extended periods of time, which may be seen in clinical practice. Withdrawal symptoms include nausea and vomiting, weakness, tachycardia, sweating, anxiety, tremor, loss of appetite, tinnitus, and delirium. So benzodiazepines should be prescribed with caution for dependence-prone people with other risk factors for drug abuse, because they can be addictive as well. Here are some examples of these. We have a couple of benzodiazepines. They all end in AM, most of them azepam, and then alprazolam is the one exception to that, and then clonazepam once again. And then we have the barbiturates. All of these end in barbital, phenobarbital, pentobarbital, etc. The last drug I want to talk about is alcohol. And alcohol is technically a depressant. It depresses the central nervous system, although it has some temporary stimulatory effects, like raising your heart rate, for example. Chronic use can lead to psychologic effects like cognitive impairment, distress, and personality changes, as well as physiologic effects like liver cirrhosis, hepatic encephalopathy, and even liver failure, gastrointestinal bleeding, cardiac arrhythmia, and ascites. Withdrawal symptoms include loss of appetite, tachycardia, we're seeing that in a lot of these drugs, anxiety, insomnia, delirium tremens, impaired attention, and memory. And delirium tremens is characterized by shaking tremors as well as hallucinations. Quitting alcohol after becoming dependent is difficult, as seen by all of these withdrawal symptoms. So, along with adequate nutrition, vitamins, and rest, sometimes administration of a benzodiazepine or beta blocker like clonidine in gradually decreasing doses can be used to help the central nervous system recover after an addiction situation. So, the U.S. Drug Enforcement Administration has a scheduling system that I foreshadowed before that classifies drugs into 5 categories, ranging from Schedule 1, which has the highest abuse and dependence potential, to Schedule 5, which has the least abuse potential. So for Schedule 1, note that marijuana, or cannabis, is still considered a Schedule 1 drug by the DEA, even though some U.S. states have legalized marijuana for personal, recreational, or medical use. Since it's Schedule 1, doctors cannot formally prescribe it, and can only recommend it for medicinal use in those states that have legalized it. Schedule 2 drugs, substances or chemicals, are defined as drugs with a high potential for abuse, with use potentially leading to severe psychological or physical dependence. Vicodin, which is one of those combination analgesics of hydrocodone and acetaminophen, is an example here, as well as most other opioids, cocaine, and methamphetamine. Schedule 2 can be prescribed, but must have a written or phoned-in prescription with literal written documentation. So in other words, there has to be some hard copy, and no refills are allowed without a written script. With Schedule 3, you still have some abuse potential, but it's less than Schedule 2. Tylenol 3 is an easy one to remember because the number matches the schedule. Schedule 4 has a low abuse potential, and this includes most benzodiazepines like Xanax, Valium, and Ativan. Ambien is a sedative, and tramadol, interestingly, is an opioid. Schedule 5 drugs have lower abuse potential than Schedule 4, and one to note is Robitussin, that's a cough medicine that contains codeine. And most of these drugs are actually over the counter and don't require a prescription at all. All right, so now for what to do with patients engaging in substance abuse. So generally, we want to screen patients for risky substance use behaviors, and when indicated, be able to refer them for appropriate treatment, whether that be a support line, addiction counselor, treatment facility, or something like that. If a patient is showing any of the signs or symptoms of intoxication that I talked about before, it's a good idea to defer dental treatment to another day and refer them as needed. So for marijuana users, due to that concern over orthostatic hypotension, recall from our high blood pressure video that we want to slowly sit that patient up after a long procedure to avoid a syncope event. Oral cancer screening is important to do for all patient exams, but especially for marijuana users who are at higher risk of squamous metaplasia and, in general, oral cancer. For opioid users, consider a short-acting benzodiazepine or intraoperative nitrous oxide if the patient requires an anxiolytic, or better yet, contact their physician ahead of time to discuss their options. Also have naloxone available to reverse an opioid overdose if ever needed. For patients high on either cocaine or meth, there should be a waiting period of about 6 to 8 hours after their last dose of illicit drug before having any dental treatment, since most of the effects will dissipate within this time. Local anesthetics with epinephrine must not be used for 24 hours after the last dose of illicit drug because both cocaine and methamphetamine increase the power of epinephrine, which could result in hypertensive crisis, stroke, or heart attack. Along with that, you should avoid all epinephrine impregnated retraction cords and monitor their blood pressure and pulse throughout the dental appointment because they are at increased risk for stroke and heart attack. And lastly, for alcohol users, research has shown that even brief advice or discussions in a clinical setting by a healthcare provider like a dentist are more effective than no intervention at all, so they are recommended for alcohol abuse problems. Excessive bleeding secondary to liver disease is possible, so lab tests would be needed to confirm this, as discussed in our last video on bleeding. Once again, screen for oral cancer because alcohol, along with tobacco and marijuana, are strong risk factors for the development of oral squamous cell carcinoma. Also very important, both alcohol and Tylenol or acetaminophen can cause liver damage on their own, but the damage increases exponentially when both substances are used together. The toxins overwhelm the liver and can cause serious long-term harm. So certainly avoid acetaminophen use with alcohol. So first, we'll do some general oral manifestations that we see in substance abusers, and then we'll focus down on more specifics for each illicit drug. Patients with abuse disorders tend to have more plaque, calculus, caries, and periodontal disease due mostly to oral neglect and overall poor oral hygiene. Along with that, we see, generally speaking, more infrequent dental appointments due to a dental phobia. And anytime one of those drugs is used intravenously, there is a risk of bloodborne infection, as we talked about before, Hep B, Hep C, and HIV particularly. In addition to poor oral hygiene and infrequent dental visits, like we talked about in the last slide, marijuana directly leads to xerostomia, or dry mouth, which can contribute to a whole bunch of other issues, as we've talked about throughout this oral medicine series. THC is an appetite stimulant, which often leads users to consume high sugar diets, which certainly will not help with caries. The immunosuppressive effects of cannabis may lead to higher prevalence of oral candidiasis as compared to non-users. Chronic inflammation of the oral mucosa with hyperkeratosis and leukoplakia can develop into malignant neoplasias, and that is seen in marijuana users as well. And lastly, leukoedema, which is this non-malignant bluish white lesion, is also seen more frequently in marijuana users, but it's unclear if the cause is from the orally inhaled smoke or the cannabis itself. For opioid users particularly, we see a higher rate of dental phobia, increased risk of caries, periodontal disease, candidiasis, and bruxism. Note that there is not an increased risk of oral cancer unless there is concomitant use of alcohol, tobacco, or marijuana, and note that there's also not an increased risk of xerostomia unless there's concomitant use of marijuana, antidepressants, antihypertensives, or any of the other number of drugs that we talked about that can cause xerostomia. With intraoral use of cocaine, gingival recession and erosion of the facial surfaces of the maxillary teeth may be due to rubbing of the powder over those surfaces. Meth mouth is seen in chronic methamphetamine users and is due to a combination of things. It's a combination of xerostomia from the drug, a high sugar diet, and increased acidity from gastrointestinal regurgitation or vomiting, resulting in rampant caries and erosion of the teeth. Now you combine that with high energy levels, which leads to bruxism and grinding of the teeth, that also contributes to wear of the teeth, as well as alveolar bone loss and periodontal diseases. So all of that combined can be very quickly damaging to the teeth, as you can see in this picture. Alcohol users are at higher risk of squamous cell carcinoma. The high-risk sites for development of squamous cell carcinoma are the lateral border of the tongue, as seen here, and floor of the mouth. Nutritional deficiency secondary to alcohol use can result in glossitis and loss of tongue papillae, which can be further complicated by a candida infection. Vitamin K deficiency specifically can cause spontaneous gingival bleeding, petechiae, and ecchymoses, all things we talked about in the last video with regards to bleeding disorders. And finally, bilateral painless enlargement of the parotid glands, called sialadenitis, which is inflammation of the salivary glands, is a frequent finding in patients with liver cirrhosis, often from chronic alcohol use. So to finish up, I once again came up with some scenarios covering some frequently asked questions. So the first one is, what do you do if a patient has severe pain and an opioid is indicated? Well, what you want to do here is check the PDMP and ensure that there's no history of misuse or abuse for this patient. Then prescribe very little if you have to, say 10 milligrams of hydrocodone every 6 hours for 24 to 48 hours, somewhere between 4 and 8 capsules only. Next, what is the best pain medication for an opioid abuser? Well, consider a nonsteroidal anti-inflammatory analgesic as the first-line therapy for acute pain management. And there's a growing body of research that suggests that combining an NSAID with acetaminophen is actually more effective at relieving acute dental pain and has fewer adverse effects than opioids. And finally, a very frequently asked question: what if a dental staff member is revealed to be a substance abuser? Well, what you want to do is approach the person privately and candidly, and if substance abuse is affecting their work, then it is appropriate to recommend a support line or counselor. And because dentistry involves being present and having steady hands, it is important to follow up with them and not ignore it completely. Of course, if the drug abuse is causing this particular staff member to become a threat to public safety, then you are absolutely within your right to suspend their work and report them to law enforcement or a treatment facility. And for a dentist who is intoxicated, they can actually be charged with public drunkenness and reckless endangerment, and their dental license will likely be suspended with possible jail time. Alright, so that's it for this video, guys. Thank you so much for watching. Please like this video if you enjoyed it, and subscribe to this channel for much more on dentistry. If you'd like to support me, please check out my Patreon page. And thank you to all of my patrons here for their support. You can unlock access to my video slides to take notes on them and practice questions for the board exams. So go check that out. The link will be in the description below. Thanks again for watching, everyone. I'll see you in the next video.